I want to circle back on the CARD data because I think it's really important for us to emphasize to everyone who's listening and thinking about this that not only was cabazitaxel better in terms of survival. There was a clear survival benefit, again, just out in the New England Journal. We also saw that actually more patients had adverse events that actually, I think, resulted in death in the AR-targeted, the layered, or the second AR-targeted arm. So big problems, I think, and that's really should not be our first choice unless there's, compelling reason from a patient perspective or they cannot take chemotherapy. I think what it doesn't exactly answer, though, and what some people have been talking with me about is what is the next best agent. It's not necessarily cabazitaxel just because we saw, I think, that it's not AR targeted or not another AR targeted agent. And just to reemphasize, you don't resensitize to AR agents by sandwiching. So AR, docetaxel AR, not any better than docetaxel AR. So just putting that out there too. But I think that the change in mechanism of action is what's going to be critical. But like Jorge said, this is the first kind of third line option trial that we have. And so if we really want to rely on data in our clinical practice, if that's how patients feel most comfortable, then cabazitaxel it is. But interestingly, at ESMO, there was some other data that was presented actually just before the CARD data, which was looking at personalizing therapy by targeting DNA repair defects. And that story is really unfolding before our eyes as well. So in the PROfound trial, these are patients, many of whom had had docetaxel, had also had either abiraterone or enzalutamide, and were identified by having one of these DNA repair defects in their germline or a somatic lesion or alteration. They were randomized to the other AR-targeted agent or olaparib, and the primary endpoint of this trial was radiographic progression-free survival. Olaparib was associated or had a superior radiographic progression-free survival in this population. Again, demonstrating that sequencing AR agents probably not going to be beneficial to our patients, but really identifying that we can personalize and target patients who have these DNA repair defects. So curious, Ken, are you using this data? Are you checking germline mutation status for patients? What are you thinking about with this?
Yeah, I think that's a great question. We started about a year and a half ago, basically in high-risk patients, looking at that, and so we are doing kind of genetic germline testing, looking for BRCA1 and 2. We're using some other agents now, using Foundation Medicine, doing some other things to get all that, because I think that's going to be the future, right? Customization of cancer care, whether it's the newly diagnosed low-volume prostate cancer who can probably go on active surveillance and never need treatment, to someone like this gentleman who's clearly failing multiple things, and how are we going to make that better? So whether that's going to be a PARP inhibitor or whatever that's going to be, I think that's where I think that germline testing is going to be critical to continue that customization of care.
Yeah, and what are you thinking about germline versus somatic, so tumor testing and thinking about when to pull that in?
Yeah, so I think the PROfound trial is the landmark trial. And, Maha Hussein, she did a great job in her presentation. This is going to revolutionize how we basically are looking about genomic profiling for all patients with metastatic disease. And that's what this trial was the first. It's really truly remarkable. It's personalized therapy, because if you have a DNA repair damage alteration, BRCA2, which kind of led the charge in this study, but we saw results with CDK12, we saw it with CHEK2, you saw it with BRCA1, and a little bit of a signal, not great, with ATM. That said, it clearly bested the switch to either an ABI or ENZA, and as you said, about 2/3 of the patients also had received taxane therapy too. And also there was an 80% crossover. So the actual benefits are a little bit blunted by that 80% crossover. Why is this important to the listening audience? Is basically you've got to start testing. If you're not testing, you're never going to know. So it's both germline and it's going to be somatic, because if it's germline, you kind of have your answer, but not all patients who are negative germline could also have, they could have DDRA defects as well. So getting biopsies, metastasis-directed biopsies, there's a learning curve to that. You have to work well with your interventional radiologist. This is all, again, part of the whole rubric of the multidisciplinary team, whether it's your pathologist or your cardio-oncologist, your interventional radiologist. Maybe we'll get to the point where we use liquid testing. It's not there yet. But there is a differential with patients, so you're going to ultimately have to be looking for somatic as well as germline. And now we have level 1 evidence, and this drug almost assuredly is going to get approved, the first PARP inhibitor, I'm sure pretty soon, that we'll be able to offer to patients. And the good news is there are several other PARP inhibitors that are being trialed in large, significant phase 3 studies. So it's going to really turn, the field on its ear, because most, I think, of our colleagues, when patients present with metastatic disease, and it's in the NCCN guidelines, they're not getting tested. So this is a big unmet educational need.
And what are you thinking about cascade testing? So part of the reason I think that people are hesitant is that they don't always know what to do with the information. They don't know which test to choose. And then they're also concerned about the implications for family members. So what do you think about that?
So in our group, we have a design. Our clinic we have a prostate cancer genetic counselor specifically for our prostate patients. But I think that you're right, Neil. If you look at the NCCN guidelines over the last 3 years specifically, we have adopted and changed every year, right? And now we used to say people with family history, then raise a flag, right, for a DNA repair. Then we talk about patients walking in the office with de novo metastatic disease, and now it's basically, or men with younger age, high volume, localized disease, but now it is clearly every patient. Now, just to be provocative again, I think this is indeed probably the most compelling trial for me than we have done in many years in prostate cancer, because it's biomarker driven, and indeed it's a landmark trial in my opinion. And I think that hopefully this is the beginning of that molecularly driven therapeutic era that we're looking for. I think my only concern with DNA repairs is that I think the utility of these PARP inhibitors, in my opinion, remains short-lived, number one. And I always use the example that if I were to walk into one of your offices as a 50-year-old guy with known BRCA2, right? And you tell me, well, Jorge, you know it, and if you didn't know, we're gonna have to work on counseling you and your family, breast cancer, pancreas cancer, ovarian, breast for your sister's family or children. And then, by the way, you do have more aggressive prostate cancer because DNA repair patients have more aggressive prostate cancer. Oh, and by the way, I'm going to be able to put you on an oral agent, one of maybe 3 in the future, that may actually be effective in your disease. But the problem is that we just don't know when to trigger that, when to put me on a PARP inhibitor. So the bigger question is right now we develop this agent in the castration-resistant space, which is pretty far out, right? And the bigger question in my mind is, well, should we actually start testing? Undoubtedly, every man with prostate cancer should get tested. But should we start using these oral agents earlier? And it should not, because we don't have that level 1 evidence. But it raises the question that maybe earlier management of these patients may, in fact, be more effective for some of these patients. Lastly is that if you look at the pre-chart data, right, clearly is the incidence of true germline mutations is probably less than 9% for most men. So it's not a huge patient population, and therefore the importance of capturing somatic changes. We also know that BRCA2 appears to be exquisitely sensitive to PARP inhibitors, which doesn't appear to be the same for ATM, maybe even for BRCA1. And there are other somatic changes that also appear to be quite exquisitely sensitive to these PARP inhibitors. So I do know that not all DNA repair deficiencies are made the same and will likely respond to the same treatment the same way. And I think that's something that the field over time will have to spell it out for us in clinical practice.
I completely agree, and I think that we may find that the PARP inhibitors themselves may not, some may be more effective than others. What was fascinating to me in the profound data was that the BRCA1 patients didn't seem to necessarily have the same benefit. So CDK12, yes. PALB2 were not even reported because they were so rare. They were actually in the 2 Part B study, so seemed to have similar effects as the BRCA1 patients, or sorry, the BRCA2 patients. So I think there's so much still for us to dig into here. I'm excited though that it is in the guidelines, and really just to emphasize, anybody with metastatic disease gets germline testing. And then I think in my practice at least, I try to work in somatic testing as well, because there are clear therapeutic implications, and we can increase the number of patients who actually end up being eligible for these treatments if we find them in the somatic. They do not need to be double hits in germline and in somatic.